Hi and welcome back. Today in pathology we will start a new topic, that is neoplasia. I will divide the entire chapter of neoplasia into 2 or 3 videos. In this first video or first episode we will discuss the definition of neoplasia, the nomenclature, the classification, the characteristics of neoplasia and staging. Okay, welcome you all. Let's start our journey. Neoplasia is defined as a mass of tissue formed as a result of abnormal, excessive, uncoordinated, autonomous and purposeless proliferation of cells even after cessation of stimulus which caused that growth in the first place. Okay, so neoplasia is defined as a mass of tissue formed as a result of abnormal, excessive, uncoordinated, autonomous and purposeless proliferation of cells even after cessation of stimulus for growth which caused it. So the growth here is abnormal, excessive, uncoordinated, autonomous, that is self-propagating, and purposeless, useless. And it continues even after the stimulus which caused it is removed. Neoplasm, colloquially in layman's term, is called cancer, and this term carcinose or cancer was used by Hippocrates to denote neoplasm, and this word cancer means crab, and this word was used because it described the true nature of neoplasm. That is, this neoplasm or cancer sticks to the pot stubbornly, just like the crab. That is why the word cancer was used to denote neoplasm originally. The scientific term is neoplasia, and the study of neoplasia is called oncology. Coming to nomenclature, or how different categories of tumors or neoplasia are named, neoplasia is generally named based on the parenchymal component. Any neoplasia basically has two components: the parenchyma, which is comprised of proliferating tumor cells and which is the major component, and supportive stroma, which is composed of fibrous connective tissue and blood vessels which provide a framework and support these proliferating tumor cells. The nomenclature or naming of the tumor is generally based on the parenchymal component. The naming is basically based on the parenchymal component and the tissue from which it originates. For example, any tumor which originates from epithelium or epithelial cells is called carcinoma, and any tumor originating from mesenchymal tissues is called sarcoma. Sometimes wrongly we use the term carcinoma to refer to any cancer, but that is not correct. The term carcinoma scientifically refers to only the tumor which originates from epithelium. The tumor which originates from mesenchymal tissue is called sarcoma. Sometimes there can be mixed tumors also which originate from two types of tumors, or which is a combined form of two types of tumors or originate from two types of tissues. For example, carcinosarcoma, which originates from both epithelial and mesenchymal component, and this happens sometimes in thyroid. Another example of mixed tumor is pleomorphic adenoma, which arises in salivary glands. Another type of tumor which arises from totipotent cells derived from the three germ layers, that is ectoderm, mesoderm and endoderm, is called teratoma, and these tumors which arise from totipotent cells occur most commonly in ovaries and testes. Another type of tumor is blastoma or embryoma, and this arises from embryonal or partially differentiated cells, and this occurs mostly in infants and children. Another benign tumor is hamartoma, and this is composed of tissues or cells indigenous to that particular organ, but which are arranged in a disorganized fashion. For example, hematoma of the lung consists of mature cartilage, smooth muscle, and epithelium, or components of or the tissues which compose the bronchus. But they are not organized to form a bronchus, but they are arranged or spread out in a disorganized manner. Such a tumor is called hematoma. And choriostoma is the name given to ectopic islands of normal tissue. There is tumor composed of entirely normal tissue but in an abnormal place or ectopic place. Now coming to classification, the current classification of tumors is based on histiogenesis, that is cell of origin, that is from where or from which cells the tumor originates, and on the anticipated behavior of tumor, that is how it progresses. Based on anticipated behavior or the progress, the tumor is divided into two categories, that is benign and malignant. What is benign, what is malignant? We will come to that in a short while. We will discuss that in detail. And based on tissue of origin, the tumor is classified into those which arises from one parenchymal cell type or those which arise from more than one parenchymal cell type, that is mixed, and the one which arises from totipotent cells from germ layers. The first category, there is tumors arising from or tumors composed of single parenchymal cell type, is further subdivided into two subcategories, the one arising from epithelial cells and the one arising from mesenchymal tissues. We will see one example of each type. A benign tumor of epithelial origin, example is squamous cell papilloma, and malignant tumor of epithelial origin is squamous cell carcinoma. I already told you malignant tumor of epithelial origin is termed as carcinoma. Here from squamous cells, so squamous cell carcinoma. Example of benign tumor from mesenchymal origin is lipoma, and example of malignant tumor of mesenchymal origin is liposarcoma. Example of benign type of mixed tumor is pleomorphic adenoma, and malignant type of mixed tumor is malignant mixed salivary gland tumor. The same way, the example of benign type of tumor arising from totipotent cells is mature teratoma, and malignant variety is immature teratoma. I have given only one example for each type. A neat table with more examples is there in our Harshmogan textbook. You can refer to it for more examples. Now moving on to the next topic, that is characteristics of tumors. We will see the important characteristics of tumors and the differences between two major categories of tumors, that is benign and malignant, with respect to these characteristics in this section. The general characteristics of tumor can be described under the following 5 headings, that is 1. Rate of growth, 2. Cancer phenotype and stem cells, 3. Clinical and gross features, 4. Microscopic features, which is the important characteristic, and 5. The spread of tumors, which can be the local invasion or direct spread, and metastasis or distant spread. Coming to rate of growth, it goes without saying, any tumor proliferates rapidly. Malignant tumor proliferates more rapidly than benign tumor. And this rate of growth is dependent upon two factors, that is rate of cell production versus rate of cell loss. There is the balance between these two, and the degree of differentiation. Generally, poorly differentiated tumors show aggressive growth pattern. Coming to the second characteristics, that is cancer phenotype and stem cells. Here you will have to note two things. One, the monoclonality of the tumor cells and the role of stem cells in tissues. So what is monoclonality? It is found out that cancer cells originate from clonal proliferation of a single progeny or a single parent cell, and this is called monoclonality. And it is also found out that most tumor arise from stem cells or totipotent cells normally present in tissues, that is adult tissues, in small number. These cells are not easily identifiable, but still it is said that there are a small amount of stem cells present in normal tissues, and cancer or this tumor generally originates from these stem cells. Coming to the third characteristic, there is clinical and gross features. Here, the malignant and benign tumor varies considerably as far as clinical and gross features are concerned. We will see that difference now. Benign tumors are generally encapsulated and well circumscribed, whereas the malignant tumors are poorly circumscribed and irregular. The same way, benign tumor just compresses the surrounding tissues. This is a very important difference. All benign tumors just compress or push aside the surrounding tissue. They do not invade or affect the surrounding tissue. So benign tumor just compress or push aside the surrounding tissue, whereas malignant tumor invades the or infiltrates the surrounding tissue. The surrounding tissue is also affected. The surrounding tissue also becomes cancerous. But in benign tumor, the tumor is well circumscribed. It only pushes the surrounding tissue aside. Coming to the size, obviously benign tumor is small and malignant tumor is larger. And as far as secondary changes are concerned, secondary changes like hemorrhage, infarction, ulceration, these are called secondary changes. And as far as secondary changes are concerned, these are seen less often in benign tumors and more often in malignant tumors. Coming to microscopic features, which is the most important characteristic of a tumor. Here again, benign and malignant tumors vary considerably. We will see the features one by one along with the differences between benign and malignant tumors. The first microscopic feature to be seen is the microscopic pattern, that is the pattern of arrangement of tumor cells. Here the point is, in benign tumor, the pattern more or less resembles the tissue of origin. Whichever may be the tissue of origin, the pattern resembles it. That is the case in benign tumors. But in malignant tumors, there is poor resemblance. There is no resemblance between the tissue of origin and the tumor. The next microscopic feature is differentiation and anaplasia. Differentiation is defined as the extent of morphological and functional resemblance of parenchymal tumor cells to the corresponding normal cells or the cells from which it took its origin. Okay. So it is the extent of morphologic and functional resemblance of tumor cell to the original normal cell from which it took its origin. When they are comparatively similar, then it is called well differentiated, and when there is very less resemblance, it is called poorly differentiated. Generally, benign tumors are well differentiated and malignant tumors are poorly differentiated. And this poor differentiation or the lack of differentiation, which is a characteristic of malignant tumor cell, is called anaplasia. So anaplasia is nothing but the lack of differentiation, which is a characteristic of most malignant tumors. If you ask me, what do you mean by poorly differentiated? Why do you call them poorly differentiated? What are the features those tumor cells have to call them poorly differentiated? So if you ask me that, I will explain that. Poor differentiation refers to certain features which we will discuss now. That is, a cell to be called poorly differentiated exhibits certain features which we will see now one by one. The first feature or the first characteristics of an anaplastic cell, that is poorly differentiated cell. Poor differentiation is called anaplasia and poorly differentiated cell is called anaplastic cell. So the first feature of an anaplastic or poorly differentiated cell is loss of basal polarity. So what is basal polarity? In a normal cell, usually the nucleus tends to lie close to the basement membrane. That is a feature of normal cell. But in a tumor or anaplastic cell, this is reversed. That is, the nucleus tends to lie away from the basement membrane. This is called loss of polarity or reversal of polarity. And this is a classic feature of anaplastic or poorly differentiated cell. The next feature is pleomorphism. Pleomorphism is nothing but variation in size and shape of the cell. Usually, tumor cells vary considerably in size and shape between themselves. Okay, the tumor cells vary considerably among themselves in size and shape, and this is called pleomorphism. This is another characteristic feature of anaplastic cell. The third feature we see in anaplastic cell is increased nuclear cytoplasmic ratio. Nuclear cytoplasmic ratio is the ratio of nucleus to the cytoplasm. Usually in a normal cell it is 1:5. One size nucleus to 5 times cytoplasm. The ratio between size of nucleus and cytoplasm is 1:5 usually in normal cell. But in an anaplastic cell or malignant tumor cell, what happens? The nuclear cytoplasmic ratio is increased. That is, the size of the nuclei is enlarged disproportionately to the cell size. And this increases the nucleocytoplasmic ratio to around about 1:1. The normal is 1:5, but in anaplastic cell, the nuclear cytoplasmic ratio is increased to 1:1. Another feature is anisonucleosis. Anisonucleosis is variation in size and shape of the nucleus, the counterpart of pleomorphism. Pleomorphism is the variation in size and shape of the cell, whereas anisonucleosis is the variation in size and shape of the nucleus. This is also a feature of malignant tumor cell. The next feature is hyperchromatism. Hyperchromatism is unusually dark staining nuclei. The nuclei of a malignant cell is unusually dark staining. Coming to the next and very important feature, the presence of mitotic figures. Malignant cells or malignant tumor exhibits the presence of mitotic figures. So what is a mitotic figure? You'll come across these mitotic figures, mitoses, these names very often in pathology, and it is essential that you be clear about it. So what is a mitotic figure? Mitotic figure is nothing but the name given to an actively dividing cell as seen in a microscope. The name given to the actively dividing cell as seen in the microscope. Actively dividing cell. Remember, this can be normal also. Actively dividing cell or active mitosis can be normal also in some tissues, even in adult. Example, intestinal epithelium, hematopoietic cells. These cells actively divide even in adults. Okay, so any actively dividing cell, I am not talking about abnormality here. Even normal active dividing cell presents certain feature when seen through a microscope. What is that feature? For that, you have to go back to the mitosis. You must have learned mitosis in lower classes. What happens in mitosis? The chromosomes condense and become chromatids. The two centrioles move to the opposite poles. They develop spindle fibers. Yes, the spindle fibers attach to the chromatids. They break the chromatids and pull them apart to the opposite poles. This is what happens in mitosis. You must have learned that. Okay, so now when seen through the microscope, these centrioles along with the spindle fibers and the condensed chromatids, they can be visualized in the microscope. They are visualized mostly as blue-purple globules, and these are called mitotic figures. So when you see mitotic figure in a section or in a slide, then you can be pretty much sure that the cell is actively dividing. This can be normal when it is actively dividing tissue like intestinal epithelium or something else. But when it is seen in an abnormal place, or when it is seen in a tissue which should not be actively dividing, then you can be sure it is a tumor, because these mitotic figures is a characteristic feature of tumor cells, because obviously the tumor cells actively divide. Now you should know about normal and abnormal mitotic figures. What I have explained now is normal mitotic figure. The two centrioles moving to opposite poles, giving out spindles. This kind of symmetric structure, as seen in the microscope, is normal mitotic figure. And this is seen in normally actively dividing cell and also in benign tumor cells. But when you come to malignant tumor cells, along with these normal mitotic figures, sometimes you can see even abnormal mitotic figures. What is abnormal mitotic figure? The normal mitotic figure is this symmetric structure, okay? But abnormal mitotic figure is asymmetric mitotic figures. Here, instead of being bipolar and symmetric, the spindles can be tripolar, quadripolar, or even multipolar. This kind of mitotic figure is abnormal mitotic figure, and this is a unique feature of malignant tumor only. Benign tumor does not exhibit abnormal mitotic figures. It exhibits normal mitotic figures, but it does not exhibit abnormal mitotic figures. And abnormal mitotic figure is a feature of malignant tumor. Now the next characteristic is presence of tumor germ cells. Both benign and malignant tumors exhibit tumor germ cells, but in benign tumors, these tumor germ cells are mostly without nuclear atypia, and in malignant tumor, they are mostly with nuclear atypia. The same way, chromosomal abnormalities, that is both numerical and structural chromosomal abnormalities, are frequent or present in malignant tumors, whereas they are infrequent or rare in benign tumors. And coming to function, in benign tumors, mostly the function is maintained, but in malignant tumors, the function is lost or abnormal. There can be qualitative or quantitative abnormality. Along with this, tumor presents other microscopic features like tumor angiogenesis, that is development of blood vessels which supply the tumor, and tumor stroma, which can be scanty or excessive, and also inflammatory reaction, which may be acute or chronic. We will not go into further detail here and move on to the next characteristic, that is spread of tumors. Tumor can spread locally, that is called direct spread, and it can also spread to distant places called metastasis. As far as direct or local spread is concerned, we saw this already. The feature of benign tumor is it expands and pushes aside the surrounding normal tissues. Okay, it expands and pushes aside the surrounding normal tissues, but it does not invade or infiltrate the nearby tissues. That is the feature of benign tumor. But when you come to malignant tumor, the classic feature what you see here is they invade, infiltrate and destroy the surrounding tissues. And coming to metastasis or distant spread, benign tumor there is no metastasis, and in malignant tumor there is or there can be metastasis. Now we need to talk about this metastasis in a little bit more detail. We have to see what is metastasis and the roots of metastasis. Metastasis is defined as spread of tumor by invasion in such a way that discontinuous secondary tumor masses are formed at the site of lodgement. Remember, the key word here is discontinuous. So there is no continuity between the primary tumor and the metastatic tumor. Okay, so here metastasis is defined as spread of tumor by invasion in such a way that discontinuous secondary tumor. There is no continuity between primary and secondary metastatic tumor. Okay, discontinuous secondary tumor masses are formed at the site of lodgement. So this is the definition of metastasis. Coming to the roots of metastasis, metastasis can take three different pathways. One, through the lymphatics, which is most common, lymphatic spread. Number two, hematogenous spread or spread through the blood. And number three, spread along body cavities and natural passages. We will see each one separately. First, talking about the lymphatic spread. As a general rule, carcinomas. What is carcinoma? I told you, tumor arising from epithelial tissue. Okay. As a general rule, carcinomas take the lymphatic pathway of spread or metastasis, and sarcomas take the hematogenous route for metastasis. It is not always fixed, but as a general rule, mostly carcinomas take the lymphatic route and sarcomas take the hematogenous route. Now, this lymphatic spread can take place by two ways. One, lymphatic permeation, and two, lymphatic emboli. In permeation, what happens? The walls of the lymphatics or the lymphatic channels, the walls of the lymphatic channels are readily invaded by the cancer cells, and there is a continuous growth through that to the metastatic site. In lymphatic emboli, what happens? Some part of the primary tumor gets detached and it is carried by the lymph to the draining lymph node and it grows there. This is lymphatic emboli. So invariably the node which drains the area of tumor is invariably affected, and this is called regional nodal metastasis. But sometimes what happens, metastasis does not develop in the lymph node nearest to the primary tumor, but actually what happens, the metastasis skips the nearest node and the next node is affected. This is called skip metastasis. And sometimes when there is lymphatic obstruction, due to the obstruction, the tumor cells can move in a retrograde manner, that is against the flow of lymph, and this is called a retrograde metastasis. Coming to the hematogenous route, I told you mostly sarcomas take the hematogenous route, and here the metastasis is based on the seed soil theory. There is good soil for the growth of good seeds theory. There is the tumor cells which move to cause metastasis should also be viable, and the tissue where it lodges or the organ where it lodges should also be helpful. That is called good soil, good seed theory. Okay, the hematogenous spread occurs based on that. Coming to the features of hematogenous spread, what you see here is the primary tumor which is drained by systemic veins, mostly metastase to the lungs. Here you should recollect your knowledge about the blood circulation. Systemic veins empty into the right atrium. From there, blood moves into right ventricle, and from there it is pumped into the lungs through the pulmonary artery. Yes, you know that. So obviously the tumor cells which take the systemic route or the systemic veins as pathway for metastasis obviously reaches the lungs. The same way, portal veins which drain blood from bowel, spleen and pancreas drain to the liver first or reach the liver first. So any tumor of this organ obviously metastasis in the liver. Same way, pulmonary veins which come from the lung to the left atrium carry tumor cells from the lungs. In case the primary tumor is in the lungs, the tumor cells are carried by pulmonary veins from the lungs to the left atrium, and from there it reaches left ventricle and then pumped to the systemic veins, and so those tumor cells can reach any part of the body. Another feature you should note here about hematogenous spread is the spread through artery is rare because the arterial walls are thick and resistant to the invasion by tumor cells, but the spread through veins is more frequent. And again, just like our lymphatics, here also retrograde spread can take place when there is some venous obstruction. Coming to spread through body cavities and natural passages. This is an uncommon route, usually not taken. The example of this includes transcoelomic spread, that is, tumor of stomach metastasizing to the ovaries through the coelomic fluid. The spread can also be along epithelium-lined surfaces. For example, the tumor spreading through the fallopian tube from the endometrium to the ovaries, or vice versa, from the ovaries to the endometrium. This is very rare, still sometimes it happens. The next case is spread through cerebrospinal fluid, and sometimes the spread can happen even through implantation. Implantation refers to transfer of cancer cells by surgeon's scalpel during surgical removal. Okay, that's about the roots of metastasis. Now coming to the mechanism of metastasis. The sequential steps in metastasis is shown here. The first step is aggressive clonal proliferation and angiogenesis. Remember, not all tumor cells have the capacity to metastase. Okay, they don't have the right biological characteristic necessary for metastasis. So metastasis occurs when a subpopulation or clone of tumor cells which has the right biological characteristics to complete the steps involved in metastasis proliferate. So also the tumor angiogenesis also plays a very significant role in metastasis, because as I told you, normally the normal blood vessels are to a certain degree resistant to invasion, but the new blood vessels which are formed as part of tumor angiogenesis is more vulnerable to invasion. So these two things are essential for metastasis to happen. That is, there should be tumor angiogenesis and also aggressive proliferation of a subpopulation or a clone of cells with a right biological characteristics for metastasis. The next stage is tumor cell loosening. Normally, the cells remain glued to each other by the presence of cell adhesion molecules. In tumor, there is loss or inactivation of these cell adhesion molecules, which leads to tumor cell loosening. The next stage is tumor cell ECM, extracellular matrix interaction. The loosened tumor cells interact with or attached to extracellular matrix, and then there is degradation of extracellular matrix due to overexpression of proteases from the tumor cells. Remember here, the degradation of extracellular matrix takes place at three levels. Firstly, the basement membrane of the tumor itself should be degraded, followed by movement of tumor cells through the interstitial matrix, and finally the dissolution of the basement membrane of the vessel wall. With the degradation of extracellular matrix, the entry of tumor cells into the capillary lumen takes place, and once they are inside, they are covered with constituents of circulating blood, forming a thrombus. This covering provides nourishment and also protects them from immune attack. This thrombus moves in circulation until it reaches a suitable site, and there extravasation of tumor cells occur. The tumor cells in the circulation attach to the vascular endothelium and then extravasate to the extravascular space. The extravasated malignant cells, on lodgement in the right environment, grow further and give rise to metastatic tumor. Coming to last topic of this session, that is grading and staging of cancer. Grading and staging are two systems which help to predict the tumor behavior and guide therapy. Grading takes into consideration the gross appearance and microscopic degree of differentiation, while staging takes into consideration the extent of spread and other clinical features also. Grading is mainly by gross and microscopic appearance, and it is based on two important histologic features, that is degree of anaplasia and a rate of growth. What is anaplasia? We just now saw that in a great detail. Okay, so the grading is dependent upon the degree of anaplasia and a rate of growth. For example, Brodler's grading of squamous cell carcinoma. In Brodler's grading, grade 1 denotes well differentiated carcinoma. That is, the percentage of anaplastic cells is less than 25% of the total cells. Grade 2 is referred as moderately differentiated with 25 to 50% anaplastic cells, and grade 3 is moderately differentiated but with 50 to 75% anaplastic cells. Any tumor with more than 75% anaplastic cells is graded as grade 4, that is poorly differentiated or anaplastic. But this grading has a few shortcomings. The important one is the degree of differentiation depends upon the site of tumor. There is variation in degree of differentiation between different sites of tumor, and so the degree of differentiation you see is dependent upon the site from which the biopsy is taken. So that is a serious shortcoming. Staging, on the other hand, along with pathologic examination, is also based on clinical examination and investigations. Two important staging systems commonly followed are TNM and AJC staging. In TNM staging, T stands for primary tumor, N for nodes, and M for metastasis. T or primary tumor is graded from T0 to T4 depending upon the size of the tumor. That is, ranging from small in situ lesion to the largest and most extensive primary tumor. It's graded from T0 to T4. The same way, the nodes or regional nodal involvement is graded from N0 to N3, and the presence or absence of metastasis is denoted by M, which is staged from M0 to M2. Remember, T is from T0 to T4, N from N0 to N3, and M0 to M2, 4, 3, 2. That's an easier way to remember. This is the general system. The criteria for staging each type of carcinoma varies, which we will see when we discuss that particular carcinoma in systemic pathology. The AJC system also takes into consideration all the three components of TNM staging, and it grades cancer from stage 0 to 4. Okay, that's about staging. We will wind up our discussion for the time being here. We will discuss the further topics in neoplasia in our next video. As usual, I have provided PDF notes of the topic in the description. You can download that. If you need any further guidance, you can mail me, and don't forget to keep the channel subscribed for more videos. Until we meet in our next video, thanks for watching. Bye.